And we've begun. So I'm going to try to get, all I have left to do a lot. I wish I had more activities for you to do is to hear me talk and just to finish the physiology stuff. I mean, that's what I've got to do. So, I mean, you'll get tired of listening to me. And maybe I can get through an hour and a half of this like we did last time and say bye-bye. I've got enough time, but it's me. How much can you stand? I can't even stand listening to me for that long. But unlike my wife, you can't say what she says to me. Lou, shut up. Again, I know exactly how would I respond to her. Yes, dear. You guys could be more fun than this. Wait a minute. I have to be just presenting a window. And I lost my window. I can't tell which one is which. Let me try this. Yeah, I got it right. So hopefully it will show all of that. We're hiding. All right. So I reloaded. Thank you. Oh, so hopefully you can just see this rather than it just shows me the next slide. So I hope it doesn't get too confusing. I'm going to run through the anatomy very, very quickly and then deal with the physiology. The take-home points physiologically. There's really three major processes, and I consider it four. Okay? And so the first one we examine is glomerular, because really it's about filtration. The second is tubular. I'm sure I have this written someplace, but it just makes me think more about it. Tubular reabsorption, then tubular secretion, and lastly, even though it's not in the classic description of kidney function or renal function, is, to me, the way we concentrate urine. And maybe that's the part that will be the hardest to discuss, and that has to do with the countercurrent system. And I think that's the most complicated. Renal is complicated by any stretch of the imagination. So there's some of the stuff that's fairly straightforward. That countercurrent mechanism is not so. And the interesting thing about that, we explore a little bit in this particular chapter as to why babies, and some of the students had MCAT already, are familiar with it. It is why when babies are born, why they're constantly in diapers and can't. There's a certain amount of conscious control that comes along, but the body at this point, this whole concentrating system for urine really probably doesn't get started particularly well until between ages 2 and 4, depending on the child. Because this system starts in utero and gradually increases over time as we build, as you will see when we get to this system. And for those who have me with the anatomy, what are called the long loops of Henle. That's really the significant feature, because that's where, and you're going to see this, and it'll remind you anatomically of what the description was, what are called the juxtaglomerular, the juxtamedullary glomerular system. And you will see that in the second. So you're going to see the juxtaglomerular nephrons. So let's begin with this whole thing, just to give you an idea of what, let me do this way. What function is about. It is so pivotal. I finished recording digestive. I did that this afternoon, just before this started, about an hour and a half ago. And I'll have it ready and I'll send it to you. There wasn't a whole lot letters. It was about a half an hour. It's fairly straightforward stuff. This enzyme, lipases break up fats and proteases break up proteins. And effectively, some we'll have to get to the smallest component. So we can't digest oligopeptides or dipeptides. It has to be absorbed, rather, amino acids. We can't do disaccharides. It has to be monosaccharides. You get the idea. To absorb things, they have to be smallest. Digestion is all about breaking it down. That's really the physiology. I think it's fairly straightforward. Digestively, it's more. I think the anatomy to me is more interesting than that. But getting to the kidney itself, this is a lot more difficult to understand the physiology. water volume, solutes dissolved in the water, intra and extracellular fluid, acid-base balance. Job one to me, metabolic wastes and toxins. That's where we get rid of them. Again, the critical piece is nitrogen, because where do we see when kidneys start to fail? We see nitrogen-containing compounds that we have to excrete the vast majority of accumulating. And those are called blood urea nitrogen, and the other one, creatinine. Two major nitrogenous compounds that we have a limited tolerance. We can't deal with nitrogen. Uric acid is another that you could look at, but perhaps less so. We see it more in gout. These are all, uric acid is from purine metabolism. That's where the URI comes from. Breaking down amino acids and the deaminating process, whatever we're going to do with them, the vast majority of times we may stick the amino group on. But again, when we're making other stuff out of the amino acids we consume as part of complete proteins, what happens? We magically take those two amino groups. I'm sure you had this biochemically. We combine it with carbon dioxide and voila, we get urea. What's the beauty of urea? It's more soluble than ammonia, right? You had this stuff, right? Breaking down amino acids. When we deaminate, what do you have? Ammonia. Ammonia is very toxic. We detoxify it by combining two molecules of ammonia with carbon dioxide. Good old carbon dioxide, the carbonic acid buffer. We get a lot of bang for our buck with CO2. And so that system gives us urea, which is, and the whole idea, it's more water soluble. That's why it effectively detoxifies. So all of these things are relevant to what the kidney has to do. The kidneys have really, and we talked about erythropoietin and all of that stuff. And then we'll review the renin-angiotensin mechanism. And again, they have this flip-flop. This is another typical PowerPoint error. I was going to use another term ending with the word up, but I'm not going to do that. Thank you for smiling. If it wasn't for you, I'd have nobody. The rest of the group here just ignores me. Okay. So erythropoietin regulates red blood cell production, and the renin is involved in blood pressure, and we'll review that in the process of going through this rather complex chapter. Vitamin D, gluconeogenesis, blah, 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 blah. Not doing the ureters. So we're really talking about the kidney. At this point in time, there's limited functionality to worry about when it comes to the urinary tract. And that, again, is anatomically the ureters, the bladder, and the urethra. Nothing is really happening physiologically there, per se. It's just the urine coming out. The tubes it comes down, the bladder where it stores, and the urethra where it exits. All that aside, the biggest problem comes from when we have excessive amounts of things that can form little granules that become stones. That's where the problem is. Or in the case of like my bladder cancer, when we have things accumulate, we get rid of toxins in our urine. When you have an excessive amount of certain toxins, that effectively the byproducts, in my case, of cigarette smoking and the quote tar, not the nicotine per se, but the tar, what's ever in there, as it breaks down metabolically, becomes a primary agent for instigating the onset of bladder cancer. The vast majority of people with bladder cancer are smokers, in enormous amount. I'm not going to review that, the anatomy, and where it's located in the adrenal glands. And, oh, by the way, it's kidney shaped, or the fat. It's retroperitoneal, and blah, 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 blah. All of those things we looked at. The key is the divide. The external area is the cortex. The vast majority of the glomeruli are in the cortical area that do the filtration. 85%. That's the solutes. That's reclaiming the sugar. That's getting rid of potassium. That's reclaiming things that are useful. Okay. Excreting things that are useless. Okay. About 15% of these, what they call nephrons, 15% of those glomerular areas are the ones that are juxtamedullary They're the ones about concentrating the urine that are there. And you'll see that without going into the tips and things, but I'll show it to you. And here it is. Again, this is the cortical area. If you remember the start of those pyramidal structures, the base or the end of those pyramidal structures going from centrally are really this elaborate series of passageways and particularly loops accompanied by what are called collecting ducts, which you'll see in a second. And effectively, for all intents and purposes, the urine drips out of the tips, is collected. Remember, you don't have to know it. Minor calyces, they lead into these major calyces that lead into the renal pelvis, and the stem, a series of funnels, is the way I framed it. And that last funnel, the stem of that funnel, is the start of the urine. So it's the complexity lies in what's going on, not so much the anatomical structure that's there. And different infections, whether they affect one area or they get within the entirety of the kidney, and not going into that per se. We'll talk a little bit about that when we get to genitourinary infections in male and female reproductive. Same with the blood supply, not going crazy. What is unique about the blood supply is important. Again, parasympathetic does not have any impact here. It's all about the way we control the physiology is based on the flow. The way we control blood flow is the sympathetic nervous system. And of course, a series of other chemicals that are involved in that as well. About a quarter of your cardiac output goes to the kidneys each minute. So right now, the largest single component of your blood right now is going to your kidneys, which is why, and I'm the old guy here, many of you have to keep running in that direction. Should be me. See, that was another opportunity. You missed that one. I hate them all. Skipping it. You might remember me basically going bananas over this. The blood supply is fairly interesting. It travels by way of these areas between the pyramids, what they call the columns. They arch out over, and the veins return in the same direction that are there. And this is where these capillary beds begin to occur and form into this interesting nest called the glomerulus, which is very unique. You got to look at it again to get the whole picture that's going on here. This has been a while since we talked about that. The key issue is physiologically to create that filtrate. The first step, glomerular filtration, is done without expending energy other than that which is part of the anatomical physiology. It's a high pressure filter. If blood pressure drops, the part that is most endangered in what we call shock, when your blood pressure drops precipitously, is your kidneys will shut down. That's exactly what happened to me. It will be 20 years ago, at the end of July. It will be the 20th anniversary. It would put me in intensive care with a salmonella infection. My kidneys shut down because of effectively hypovolemic shock. So understand that's what this is kind of all about. The high blood pressure allows the afferent arterioles to have a sufficient amount of pressure gradient to force out effectively the vast majority of everything that's in your bloodstream. The only thing it does not push out of this interesting capillary bed, this interesting nest of fenestrated capillaries, little windows, and we can control little slits, is nearly all of the fluid and none of the formed elements. So protein, red cells, white cells, and platelets, too big. Everything else, all the things dissolved in the plasma, and the vast majority of the plasma itself goes out. And our body physiologically reclaims this. That's why we have this unique area of an arteriole leading into a capillary bed and leading into another arteriole. Normally, you go into a capillary bed, we get into a venule. and the red would turn to blue. Didn't. Okay? The whole idea is we're not using the energy contained in the oxygen and whatever nutrients are in the bloodstream, nor are we picking up any waste products on our travels. It's maintaining arterial blood. Then, whether it goes through the two glomerular structures, what they call nephrons, that's technically the true structural and functional unit, they're either going to go into peritubular capillaries or vasa recta. That's when these interesting exchanges, that's when the reabsorption and the secretion take place. And that's where the energy contained in that oxygenated blood is expended, and it picks up waste products and becomes venous blood, eventually following the same pathway anatomically on its way out to be collected by way of the renal vein into the inferior vena cava. The whole way is it's structural. You remember making a big deal out about this because the renal artery is disproportionately wide. Remember, above it, the suprarenals are narrow, they're tiny. Below it, the gonadal arteries are tiny. Below it, the renal arteries are wide and short, high blood pressure. They very much mirror systemic blood pressure. So there are the nephrons, 1 million per kidney. And so we're going to look at basically both of these parts, reviewing the corpuscle. Okay, that's the glomerular portion where the filtration effectively occurs, and we produce this thing we magically call filtrate. And then the tubular system where effectively we're forming the urine and either pulling back much of what we need and getting rid of much of what we don't. That effectively is our journey through the kidney, much of which we will do today. I know you're excited. Okay. I wish you were more fascinated by learning, but it's okay. The glomerulus. I realize it's a chore, and we're in the middle of April. We have about 3 weeks to go, and then you're done with me. But more important, I'm done. But I'll be watching you. The glomerulus. These interesting capillaries, porous. Remember, fenestrated capillaries, little windows, little openings. Okay, and that fluid, which we call filtrate, we're going to produce a tremendous amount, as you'll see, volume wise. During a typical day, most of us effectively form 160 to 180 liters of filtrate, 40 plus gallons. And we reclaim 99% of it. So that all but 1%, effectively that 1% is what you and I call urine. So most of us excrete in urine by voiding 1.5 to 2 liters a day on average. Just saying. And so you might remember the anatomical structure. It's a neat little structure. And again, I like to use the analogy of funnels. You get this tuft of capillaries where the inflowing or afferent arteriole goes in and the efferent arteriole goes out. Anatomically, the afferent is wider. That's where we can control the area. Hi, everybody. We have guests. Be on your best behavior. So the afferent arteriole, which is wider, coming in, the efferent arteriole, which is more narrow, coming out, and we collect this, and that's again an area where we can have it controlled. And so you have this nest of capillaries and surrounded a cup. It's more than just a cup. It's a cup that sort of embraces it and surrounds it. It's called Bowman's capsule. So as this effectively, it's almost like a little ball of capillaries and it spritzes out. We have that high pressure. It spits all this stuff out and it's captured by this sort of surrounding funnel with a stem. And the stem of that becomes the start of the tubular system. And the first part of it that comes out is what we call the proximal convoluted tubules. Because all the twists and turns. Twists and turns? Gosh, no fun. Right, parietal and visceral, we can deal with that. podocytes, little foot processes that can open and close little slits for filtration. So we have subtle ways of increasing and decreasing the amount of filtration, subtle ways of rerouting it. And again, if we have to retain fluid or in fight or flight, so you don't have to stop in the middle of running away after some bad guy chasing you, okay? But you have to go run to the bathroom. Remember I told you that with fight or flight, it shuts down that vast majority of the flow and redirects it. Oh, it's crazy. As a kid, did you see in the newspapers some masked guys came in and shot up a Chick-fil-A? Not in Union, New Jersey. It's probably the same location where I worked in like a burger and KFC joint. Oh, I don't know, 60 years ago. Route 22 in Union, New Jersey. Like 5 minutes from where I grew up, 10 minutes. I'm like, wow. And they're just showing you the anatomy. That's not part of it. And so what this leads into, and you'll see the anatomical diagram, and I know this is a review, but it's important. You're going to see, and it's not that terribly long, we're not 3 centimeters is barely more than an inch, this system. And you're going to see it starts with the proximal convoluted tubule as it exits that renal corpuscle, that glomerular structure with Bowman's capsule, into a loop. Long loops are different than short loops, you will see. And then a distal convoluted tubule, and then multiple distal convoluted tubules fill the collecting duct. So that pyramidal structure is all the loops and all the collecting ducts that are there. Most of the cells anatomically, and again, this is anatomy, not physiology, are basically, and it's almost a hallmark location for it, is a simple cuboidal, and the ones that have a little bit more mitochondria and a little bit more microvilli or proximal, the ones with a little lesser distal. The vast majority of the reabsorption and the secretion occurs in the proximal convoluted tubule. If you want to paint with a broad brush, in general, proportionally, considerably more absorption in proximal and considerably more secretion in distal. But the reality is that about 2/3, 3/4 of all the reabsorption, what they call absorption, and all of the secretion occurs in the proximal convoluted tubule. They're different, as you'll see the anatomy very shortly, and this is the mirror of anatomy and physiology coming together. It's all right. So here they are. This is what I mean. Whenever you see a lot of mitochondria, it's a busy cell. And a lot of microvilli, that surface area, it's a busy cell. They used to call it the loop of Henle. I think that's pretty much reserved for the long loops that are there. And again, just a reminder, descending limbs are thin because they're very permeable to water. Ascending limbs are thick. And because of that, they're more often moving solutes in and out, typically by active transport. So you don't know if you do much there. Distal convoluted tubule is different. You have less microvilli because it's not as busy, and less mitochondria because it's not as busy. And this is really what that area, that clear area, is sort of the surround of the Bowman capsule. So you have in here, and so they're showing you the proximal convoluted tubule kind of starting here. Here's the glomeruli, the surrounding cells are the Bowman's capsule, and it gives way into this collecting system, I beg your pardon, into this convoluted tubule system within. You can sort of see, whenever you see circular nuclei, remember that's cuboidal cells that are there. And that's about it. We're not too worried about the anatomy of the collecting ducts or anything like that. But this is an important one to look at. This is the sort of the general view that you can see that's there. It gives you an idea, and it's like I explained it to you in anatomy, it's sort of spread out so they're much, much closer together. And you can see the wider incoming or afferent arteriole, and then going out the efferent arteriole proportionally narrower. You can see the way it's sort of enveloped. It's not just a little cup down here, like you'd have a funnel at home, but it's something that surrounds it, because it sprays out You can see the proximal, the loop, thin here, thicker there, distal, and then multiple entry points of the collecting duct. So that's the way to look at that. Cortical nephrons, the ones that are in the cortical area, that vast granular area on the sort of the outer perimeter, the vast majority of those, that's all about solutes. The juxtamedullary ones, those long loops, all the way down, that's what make up the pyramids, and that's all about the countercurrent system and concentrating the urine. So they're a really good graphic to see how packed together they are. So you can see, and that's when we're going to look at that next thing, what they call the juxta, Juxta, for next to glomerular apparatus, that whole renin, angiotensin, aldosterone mechanism. Yes, we're going to visit it again. You don't have to thank me; it's part of the service. So here you can see the two different capillary beds. These are called peritubular because they're around the proximal and distal convoluted tubules. And these are called the vasorecta because they're straight. They're sort of draped over those long loops that are there. So that's the difference anatomically. Oh, I needed that. It's hard to watch golf all weekend. Get comfortable, have something to drink, make sure the dog is not being noisy. You know who was there at the Masters this weekend? Did you see? Mike Tomlin. Yeah, he was. His daughter goes to the University of Georgia. I bet you they went together for that. So, moving on. Renal tubules. Glomerulus, peritubular capillaries, vasorecta, done with that. Afferent and efferent arterioles. No, enough said about that. These capillaries are very porous. So again, this is where a lot of water and a lot of solutes are going to be reabsorbed that are there. The vasorecta, specifically, water going out the thin side, balanced out by solutes having to move out the other side. And you're going to see the way, when we get to it, how the gradient is maintained and what's going on. That's a great picture, a really good image of what these really look like. So, I mean, here you have a true micrographic look inside and how elaborate those are. And this takes us to the first real physiological point, the juxtaglomerular complex. We mentioned it in anatomy, as you remember, or you should remember. Those who were fortunate enough to hear me drone on in anatomy. So it's typically the distal portion of the ascending limb of the loop, maybe even sometimes a little bit of the distal convoluted tubule, typically around the afferent, or it could be the efferent arteriole. And this is where it is, and it's maintained by this. Remember, there's three areas that combine it. In the ascending limb, you have what's called the macula densa. Those are chemoreceptors. It's part of the physiology. They're sensing salt content. You have granular cells, so-called JG cells, smooth muscle cells on the arterial side, and they're mechanical receptors for blood pressure. And within those granular cells are granules that contain renin. And again, the secretion of that renin, when blood pressure is sent, when those mechanical receptors are not stimulated sufficiently, is the way we, and understand our blood pressure is auto-maintained. As long as that, and this is where we get back to the mean arterial pressure. As long as your mean arterial pressure is in a reasonable range, usually maybe as low, remember it's the mean, as 80, and it's high, sometimes up to 160 to 180. I mean, your kidneys will kind of control themselves. We don't have to do a whole lot. That's there. They'll adjust automatically to fluctuations in pressure, and if necessary, they'll release the renin, and then you have that whole renin, angiotensin, aldosterone mechanism. And you should remember all of the parts and what it does. And in between them, the mesangial cells, I think of them as messengers. okay, between the arterial and the tubular cells, gap junctions. When they say, and again, whenever you see a permissive terms, it means we're not sure, but likely this is signaling between the two to get the appropriate response, whether you have to release the renin or whether we can just make an adaptation with regard to the diameter of the blood vessel. Works for me. And again, this is the complexity. I can recall, I mean, while I was a student during a rotation at the Vets Hospital, and this like a first year resident, because we only had blackboards then. I mean, I go in there, it's like a break room. I'm wondering what he's doing. All the boards were covered. I said, "What's up?" I didn't know the guy. He goes, "I'm trying to figure out this kidney problem." I mean, it was so complex. And it turned out the attending, his name was Dr. Falls. I can remember that pretty clearly. This attending was a nephrologist. So it was internal medicine rotation. And a nephrologist, he goes, and he comes in and explains it. It's just, in those days, as my student days, that's rare. Very, very interesting stuff. So here again is the look. You saw this anatomically. So within the arterial, so here you have chemical sensors. Here you have mechanical sensor. Here, the message between them, and it will control different things. It might control some of the slits that are there. It may control the diameter, widening it or narrowing it. It may control the release of renin. All of those are possible in this situation, in this sort of interesting sensing system that's there. So here's the idea of the fluid that's processed. Typically 1.5 liters of urine. In the hospital, sometimes we'll measure those for patients in the hospital. A lot of times, particularly if they're catheterized or we're concerned about fluid, we'll have them either collect their urine and measure it before it's discarded, or do it over a 24-hour period. You mentioned what's called I&O, intake and output. And you know what they're ingesting, liquid or solid, how much effectively fluid there is. So you'll see when we're on a chart, monitoring I&O, intake and output. So the entire plasma volume 60 times a day. Let me see. That means every hour, the entire plasma volume is going through those kidneys 2.5 times. They're busy. 20-25% of the oxygen, that's based on the blood flow. The filtrate, blood minus, is basically plasma minus proteins, and the cells are not in there. And we excrete about less than 1% with anything we don't need, waste products and metabolic waste products. And here they are. The major product, this is classic physiology, filtration, cell and protein free. If there's cells or protein in there, when you do a urine, whether you're doing one because you're having a physical or you're seeing a urinalysis, and we cover urinalysis here, first thing you look for, what's in there? You do the chemistry, you do a dipstick with the chemistry, proteins, sugar, ketones, all those you can dipstick, read them like a little color chart that you would have, like if you have a pool at home and you dipstick it for chemicals, same deal. And so you're looking at that right away. That's kind of the stuff that you're looking for that's in there. Tubular reabsorption, 99% of the substances, talked about that, and secretion, selectively moving substances from the blood to the filtrate and collecting ducts. In other words, we're reabsorbing it, the vast majority, and sort of we're getting rid of what we need to get rid of that are there. And it just shows you graphically, I don't get a lot out of that. Passive process, that's why it's arterial to arterial. The fluids and solutes through that membrane into the capsule. No reabsorption until into the capillaries of the glomerulus occurs. We're not going to start reabsorbing until you get into the proximal convoluted tubule. And again, fenestrated epithelium, these little foot processes, hence they get the name foot cells, podocytes, control the openings on their slits that are there. So larger things can't get through. And this looks very much, as you will see, the micrograph, that system, even the artist rendering, wider, incoming, narrow, outgoing. You can see these areas are going to focus on the slits in the next slide. Here you can see Here are these foot processes that can control the openings themselves. You can see the tiny holes, the fenestrations. This is what it looks like. That's the micrograph that led to the artist's rendering. So it's well studied and very complicated. Again, to reiterate the point, we need about 1/8, about 12.5% of our total kidney function. In other words, a quarter of one kidney. And again, that's that two-edged sword again. When somebody all of a sudden and 75% of people have to go on dialysis are diabetics, and the vast majority of the others are systemic lupus erythematosus patients because of all those protein-laden nodules that clog up the kidney. It'll be fine. And all of a sudden, it's like, I'm really having trouble urinating, and all of a sudden, it's like, well, now you're going to have to be on dialysis. It's that two-edged sword of having when you get to that critical tip, everything's fine until you get to that tipping point. Just like with respiration, a lot of times with circulation, as long as there's blood going through until it reaches that point, all of a sudden, next thing is a heart attack or a stroke. It's really if you get nothing else out of listening to me for the better part of this last year, for most of you, is to understand, no matter where you're going, to think about that with vis-a-vis lifestyle, diet, activities. Because as I look out in the crowd here, I see you're a healthy looking crew. Stay down. Don't smoke. For many of you, the words drinking in moderation would be an appropriate thing to say. I've had that conversation with my kids. It's just they don't listen. Other than my middle one, who doesn't really drink. But thankfully, none of them smoke. So here's what's happening. The little slits and things like that. And all they're talking about this is, okay, you have a lot of those mesangial cells will help to gobble up certain things that are there. So look, only molecules smaller than 3 nanometers. So go back to biochemistry, small. Water, glucose, amino acids, nitrogenous waste. Large stuff isn't supposed to get through. If we see proteins in the urine, if we see red cells in the urine, we see white cells in the urine, we know there is a problem. This is coming directly from the bladder or the ureters. If it's coming from the kidneys and there's a way to identify it, there's a problem. And so here's the physiology of it again. Hydrostatic pressure, because of it's a high pressure filter and the wider renal arteries, okay, effectively create all the way down. Think of where it was in the heart, roughly 55 millimeters of mercury. Compared to other capillary beds, it's more than twice as much. The efferent arteriole is high resistance. It's able to resist that higher pressure. Unlike other arterioles, they would effectively burst or tear. And so what's pulling it back in? Again, we have a certain amount of fluid pressure within that Bowman's capsule space. And then we have the colloid osmotic pressure, the proteins that are left in that still are within those capillaries that are holding on to the fluid. Again, same thing we looked at cellularly before when I showed you those numbers before when we talked about cellular respiration. Same deal here. The hydrostatic pressure is pushing the fluid out. The colloid osmotic pressure and the pressure of the fluid within the capsule are effectively pushing it in, but the net force is 10. Okay, and that's what's going to cause the filter. We call that whole thing when we're looking at what we call GFR, glomerular filtration rate. And I forget, when I showed you my blood tests, remember me showing your blood test, that panel? See? Who else shows you their blood tests? Okay. They, based on the chemistries of all those tests that are done, when they do the basic metabolic panel, they estimate this. Okay, it's a snapshot, of course, but it's able to tell, like my internist, which goes, okay, this is a good number. You're over whatever that was 60 or 65. And that means your kidneys are functioning. When you slip below it, then you start to have a concern. Is there something going on in those kidneys? And again, as folks get older, this is kind of the stuff you look at to see if there's problems that are there. So they're just showing it to you diagrammatically. So the GFR, the volume of filtrate formed per minute by both kidneys, is normally at this level. So when they do that estimated test from blood tests, they're not calculating this. This is calculated differently. It's calculated, and they go over at this end. They take a carbohydrate and give you a test load of it that is neither absorbed or secreted. So whatever you intake, you should pass. And they give you that, and what you do is you have the patient did this, and this is still done. They collect, and sometimes you have to do this with patients. They'll have to collect their urine for 24 hours, and you want to see if it all came out. And that's a way to be assured that the kidneys are functioning properly. So maybe the tests are more advanced. And again, this is what we used to do. And again, the last time I was, looking at the results of 24-hour urines was more than 25 years ago. It's getting harder to say that. Okay, NFP. So this is your filtration pressure, surface area, permeability, obvious things that play a role with regard to the degree of glomerular filtration. And so these are the controls. And so it allows the kidneys to generate that filtrate and maintain homeostasis, okay? And the goal is and most of the time it's our intrinsic controls. It auto-regulates. We don't have to worry about it. Increased glomerular filtration causes increased urine output, which lowers. If your pressure's high, your body basically says, we have a fluid overload, get rid of fluid. The more we push fluid through the glomeruli, the more we're going to urinate. It's basically what it does. So how does it increase that? It increases the amount of flow coming in. It restricts the outflow. The more that it's flying around inside those tufts or beds of capillaries with the little holes, it's going to produce more filtrate. Mechanically, you're going to get rid of more water. That's the whole idea. For years, that was basically the whole idea of treating blood pressure. We basically used fluid pills. They made you diurese more, so we call them diuretics. That was the classic. The problem is, they put me on those years and years ago. But so every 40 minutes you're running to the bathroom. Eventually you can learn to tolerate it. Your body gets accustomed to it, but that first 6 months to a year is very inconvenient. I was treating patients at the time. It's in the middle of a surgery, it's hard to stop. You know what I mean? It's a little different in a big surgery. Surgeons step out in the middle of an 8-hour surgery, and they'll have another part of the team will take over. They can come back in and scrub back in. It's a little bit different for those kinds of things. We didn't do that because I was doing all my procedures. No helpers. So the goal of those controls is to take care of it kind of by itself. Okay, it auto-regulates it. So there's nervous system mechanism. These are what we're looking at now. So as long as the mean arterial pressure is roughly in this range, I would be a little suspicious when we get to these ranges that are starting to approach about 150. You're starting to really tax the system. That means you have significantly high blood pressure, and you're making bad things are going to happen. Your heart's going to enlarge, and eventually that's a slippery slope. It's going to occur. Initially, that's there, but that's why we check our blood pressure. And the trouble is, high blood pressure, as you learned previously, is silent until it gets to the point where it's a 5-alarm fire. There's not a lot of middle ground. So there's different mechanisms that are there. And to see, these are basically what is going on. looking at to see if there's a message. So these are just have to do with muscles that are there. Stretching it leads to constriction of the afferent arterioles. So if it's, as you can see, restricting blood flow, and this way it's if the excessive high blood pressure, this will limit the damage. It's like any filter, like bits of filter paper, whether you're using it here in a laboratory where you have a coffee filter. It's the reason it drips slowly as opposed to putting it on, take that and put it under a faucet and turn the faucet on high, it's going to tear a hole. And then these different feedback mechanisms responding to sodium chloride concentration. Okay. And all of these, you adjust the flow accordingly. That's there. And so, again, these mechanisms, and I'm not going to go into the details of for this with high salt, with low salt, but just in general to understand if we have the rate increasing, the filtrate flow increases, and if it goes through faster, we have less time for reabsorbing. Okay? And that means we get more salt going out and causes constriction of the afferent arteriole, which then lowers it, blah, 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 blah. Not a big deal to understand it. Okay? These mechanisms are more often involved. These are the extrinsic controls overriding the internal controls. Number one, fight or flight, sympathetic nervous system. Normally, the blood vessels are dilated, and the autoregulatory mechanisms are there. What happens afterwards? The sympathetic system predominates under abnormal conditions. If the blood pressure starts to drop, and you have to control what's causing it to drop. If somebody's bleeding out, then something has to be done about it, but that's different. But at least initially, the sympathetic nervous system will kick in for a variety of reasons. Norepinephrine and epinephrine, we talked about that before. Vasoconstriction, increase the blood pressure, constricts the afferent arterioles, less glomerular filtration, less flow into the kidneys until things increase. The other is, and the main way, the one to understand more than any others, is the renin-angiotensin-aldosterone mechanism. So I was doing the presentation on COVID for the micro class. I'm doing both of them. And the initial COVID-19 outbreak back 6 years ago, almost to the month, back in 2020, when we stopped here on site in March, they targeted receptors for this angiotensin converting enzyme. And that's really, those receptors were altered and damaged and began to secrete not anti-inflammatory compounds, but pro-inflammatory compounds. And that started that vicious reaction that people who got severe respiratory distress with COVID, particularly people at risk. So there's different ways. The sympathetic nervous system will trigger it directly and release those granules. Okay. When the sodium concentrate, when you can see, when salt concentration is low, you want to make less filtrate to retain because you have to keep those electrolytes in your system. Or if there's an insufficient amount of stretch on the granular cells, that means the pressure is low. We've got to bring that back in and pull it in. So what will happen, without going crazy about the graph, because you can read through this, if that glomerular filtration rate drops, we want to increase it. Okay, so we want to increase it by a variety of mechanisms. And again, you involve this renin-angiotensin-aldosterone mechanism. These are autoregulation here on the left side. On the right side, we have neural controls. It's near likely an override. But here is the one that we don't have to worry about, the hormonal one, the renin-angiotensin mechanism. So those granular cells and that whole juxtaglomerular complex are triggered. Typically, if blood pressure is low, renin is released. Renin goes into the bloodstream, and as you can see, it catalyzes a cascade that eventually goes first to what's called angiotensin 1 and then angiotensin 2. So angiotensin 1 is in the bloodstream. So renin catalyzes angiotensinogen, the precursor form to angiotensin, sometimes called angiotensin 1. When it gets to the lungs, so this happens relatively immediately in the bloodstream. When it gets to the lungs, in the lungs, we have what's called angiotensin converting enzyme, part of my sloppiness, known as ACE. That's the way to remember it. Those are the receptors I was talking about. And what they do is that ACE takes I'll just put angio 1 and catalyzes that to the active form, angiotensin 2. That's the big player. And what angiotensin 2 does is a lot of different things. Its name tells you one, it constricts systemic arterioles, increasing peripheral resistance. It's tighter, blood pressure goes up. It causes thirst by way of the hypothalamus. It causes the release of antidiuretic hormone by way of the posterior pituitary. That inserts little openings in the distal convoluted tubules and the collecting ducts to pull in water. Okay, and lastly, and perhaps most importantly, it triggers aldosterone release by the adrenal cortex, and aldosterone also inserts basically openings, protein openings that enable the transport of sodium, okay, back into the bloodstream. And when sodium goes, water is sure to follow. I'll save you the Mary Had a Little Lamb thing. See. Please. One of the jokes. 3 o'clock, not one smile. One smile. It's all right. Be happy. Maybe in a half an hour, I'll tell you, let's get the flock out of here. One shepherd to the other. Remember? It's a sheep joke. It wouldn't work with lions. Let's get the pride out of here. Remember, there's no free pride. Gaggle of geese. I'm trying to think of another one. I don't. Herd of cows? Of course I heard of cows. Who hasn't heard of cows? No, I mean a herd of cows. What do you mean? Of course I heard of cows. No, a whole group of cows. Well, I've heard of them. Abbott and Costello. I should play that for you. You have a greater appreciation. So, paracrines, again, chemicals that work locally. Adenosine and prostaglandins. So, and some cells even make their own angiotensin 2 to reinforce it. So it gives you an idea what happens with these things that are there. All of these. So, I mean, again, that's the type of thing. So what happens if we drink coffee in the morning, as many people do? Okay. What that does is it blocks adenosine receptors. So the adenosine isn't there. And what happens is it acts as a stimulant. Adenosine is more of a relaxant. So when we block its activity, indirectly it becomes a stimulant. That's why if you drink a bunch of coffee in the morning, you're typically running to the bathroom. And this, when someone does not have less than 50 milliliters a day, that's less than 2 ounces, really, we're either significant low blood pressure or there's something that's creating either what's called acute glomerulonephritis, which is kind of what got me in. There's a toxin, you have extremely low blood pressure. something has caused the kidneys to shut down. I emphasize it time and time again. The kidneys have one response to abnormality. If there's not enough blood pressure, they shut down. If they're clogged, they shut down. If there's an infection, they shut down. They just don't. It's the nature of the kidney works fine unless there's anything that impedes it from doing its job. Its innate responses to shut down. So you can see all of these that they're talking about. Acute nephritis, some inflammatory thing, could be infection, could be some other transfusion reactions, notoriously, crush injuries, which really put a lot of damaged blood cells into the party right away, and thus ends that part of the PowerPoint presentation. Make me look good here. I'm coming. I like that. Point 2. We'll go over these steps and I'll save, in the interest of not boring you to death, the countercurrent mechanism for Wednesday. Bad news. Dr. Badger is going to observe me in a different class. So you don't have to feel compelled to ask a bunch of questions. You have to do 2 observations. It's like the Addams family. Knock once for yes, knock twice for no. Knock 3 times and blink once for yes. Blink 3 times and knock twice for no. I hate people. You're trying me nuts. I realize you're busy and watching television shows. It's not high on your list. Resorption. Most of it occurs in the proximal convoluted tubule. The vast majority right away. Okay, relatively quickly. And it's absorbed through those lining cells, which are, again, mostly simple columnar. Almost all organic nutrients are reabsorbed. Water and ion reabsorption is hormonally regulated. Active and passive resorption occurs. So substances 2 ways, either through the cell, transcellular, or in between the cells, paracellular. You're just showing, that graphic you don't get anything out of. Solutes enter apically, travel through the cytosol, exit in the base or the sides of the membrane of the tubular cells, enters the bloodstream through the endothelium of the peritubular capillaries. By that. Paracellular, which is certainly limited by tight junctions, but in the proximal portion of the nephron, it's a little more leaky. So look at the things that are able to be reabsorbed without having to transit their way through the cell. Water, calcium, magnesium, potassium, some sodium in the proximal convoluted tubule move by this route rather. So this, and to show you graphically what it's about, and you would have known this anyway. Water insertion, solutes, transcellular, and even some, as you can see, can make their way through this. So this is transcellular, either directly or laterally, and here the peritubular route that's there as well. So it demonstrates it to you fairly well. And you can go through all those. I can't even read how small those prompts are. This is part of it. Most of these things, and if you listen to what I talked about digestively today, the absorption of amino acids, the absorption of glucose, most of these are secondary active transport. We're using sodium as the primary mover, and then secondarily bringing in other things. That's a pretty consistent pattern. So sodium is the most abundant cation in the filtrate across the basolateral membrane of the tubular cell by way of primary active transport, pumps it into the interstitial space. Sodium is then swept in bulk flow into the peritubular capillaries. So we're reclaiming the vast majority of the sodium. No question about that. So the sodium enters at the apical surface, okay? Secondary active transport, facilitated diffusion also applied. So we have a lot of different things that are there. Sodium at the basolateral membrane, low intracellular sodium levels facilitated. Potassium goes in the other direction, okay? It's there because potassium tends to leak out into the interstitial fluid. Again, the cells aren't a whole lot different if you go back and think about resting membrane potential. We always have those leak channels for potassium that are there. And so we do create a certain amount of electrical gradient because of that to induce the sodium back in. So sodium, primary active transport, and that's the energy. Again, so we use secondary, created by the pumps, typically at the basolateral surface, okay? So organic nutrients, glucose, amino acid, ions, and vitamins. That's important physiologically. It's the same thing that happens digestively. That's why, I mean, it's rare that you see extreme abnormalities in sodium. Most of the time, unless, I mean, if you're dealing with kidney failure, if you're dealing with some type of metabolic disease, that really is an influencing factor. Every so often you get people who have what they call idiopathic. This is my first wife had this to a certain extent. And I think that she had idiopathic hyponatremia. So idiopathic means there's no reason why. That's obviously understandable. It's a mystery. Hypo, too low, natremia, sodium in her bloodstream. And so, I mean, and it's relatively easy to compensate just to increase the amount of sodium intake in the day that one would have. Okay. Go, God, you can get that from fast food in a meal. So, passive tubular absorption of water, moving to the sodium, osmotic gradient for water. Sodium goes in, water is sure to follow. Okay, aided by aquaporins that are always present in the proximal convoluted tubule. And this is the different one. The facultative water resorption, those are aquaporins, water channels that are inserted into collecting ducts in the presence of antidiuretic hormone. That's what occurs when we talked about what occurs when angiotensin 2 becomes activated. It's such a big player. It's so interesting that however COVID came amongst us, that it targeted this really critical mechanism that had so much to do with blood pressure and then released all this inflammation, did an extraordinary, I mean, all the fluid that was moving into people's lungs that were there, that were at risk. It's crazy. Like I honestly thought, although I was happy to think against it, that I that whole conundrum of the shot v the not the shot for the immunization that was there. If I recall specifically looking at my family doc who's retired by now and going, I think I'm pretty healthy. I think I'd likely survive if I got it. And he goes, yeah, you probably would. It's a question of how sick you might be in the process. Never really got it. Solute concentration in the filtrate increases as water is reabsorbed. Okay. So what happens if you're pulling in water, you're going to proportionally have more solute. And then so as the sodium is going in, the water is following it. And now you have gradients because of the water, because it's becoming more concentrated, which will push the other solutes in as well. Okay. So fat-soluble substances, ions, urea will follow water into the peritubular capillaries down those gradients. So even fat-soluble substances will follow because they're going to play more by simple diffusion. These others will follow by having effectively facilitated diffusion. This is the other thing that's interesting about it. And I always like to make that note, the idea that most drugs are lipid soluble. Fat soluble things stay in your system a long time, comparatively. And so, for instance, the anecdotal way of saying it, if you wonder when you have to treat somebody who's an addict and their addiction is cocaine, we randomly drug test 2 or 3 times a week. You have to do it that often because that's something that will not be retained. It will be excreted out. It's inherently water soluble. So you randomly do it because if someone uses 48 to 72 hours, it's gone. They'll test negative. Whereas when people use, I don't know how serious they are about it now, given that there's a lot of states where marijuana and the various, the THCs, all that type of stuff are legal now, CBD and THC products for recreational use, and in some states strictly for medical use. Effectively, that stays in your system a long time, comparatively speaking. So in a hair sample, that would stay in for a very long time. I tell you this because eventually you guys are, and many of you are already, work in facilities that require drug testing to get the job. Be aware of that, please. So they're just showing you the mechanisms for this and the mechanisms for this by one of these things. I don't get a lot of use out of reading these individual ones. This to me is really important. We're getting close to where my voice is going to give out. I know you'll be happy to hear that. Skull. I talked about this in transport maximums. We talked about diabetes, and I'm telling you now, I can't stress it enough. This is a problem. All of those transport mechanisms that go through the cell are based on effectively occupation of those transport passageways, the receptors, if you will. And like any other protein passageway, if it's occupied, there's a maximum number of those that are available. Once they're all occupied, nothing else will get through. So almost every resorbed substance has a transport maximum. And certainly the glucose one is the most important. It reflects the number of carriers and immunotubules that are available. When they are saturated, it has to spill out into the urine. That's why it is so critical. I can't impress upon you enough because you're going to know people are in your orbit already with diabetes. This is why it's so important for them to control it. If you are not keeping it under the transport maximum, what it does, it doesn't just, not just the excess secreting. When those carriers are occupied over time, they become less effective. And effectively, the transport maximum, the longer it is at maximum, begins to not raise. They don't make more of them. They become less efficient, so it lowers. So let's say arbitrarily, and it's about this, the transport maximum for glucose is about 180. And so diabetic is over 180 milliliters, under 180 milligrams percent, rather, in their bloodstream when they do the glucometer test. When it gets to there, now they're all occupied. The longer it stays there, all of a sudden the transport maximum months, a year later, now it's 170. That's why most people who monitor diabetes, most people who are diabetologists, internal medicine, family doctors, even in diabetics who are relatively labile, unstable, you're efforting to try to keep that number under 150 because that prevents long-term complications. The longer those transport maximums are occupied, the more it's going to eventually accelerate kidney disease. Again, I said it before, 75% of the people who are on dialysis are diabetics. 75% of the people who have blindness, if you want to call it secondary blindness that they develop metabolically, diabetes, heart disease, diabetes. And that's why sugar control is so vital to understand. I mean, there's so many areas with regard to it. So hyperglycemia leads to high blood glucose when you fat. They exceed the levels that exceed the transport mechanism, and that's why we look for what we call spilling into the urine. When you see this, years ago we had a dipstick all the urines. Now you have the advantage of the finger sticks and the glucometer and a variety of different ways, and a lot of the continuing monitoring system. The advances technologically are significant, but it still has to be done. The proximal convoluted tubule, 2/3 roughly, all nutrients, glucose, amino acids are reabsorbed. 65% of sodium in water, many ions, almost all the uric acid, about half the urea. Interestingly, that's something we want to get rid of. That's where urine gets its name. What we're trying to do is basically, think of it, we're trying to secrete, we'll absorb stuff, create concentration gradients so we can excrete it, and then secondarily bring things along to the party that we want to excrete. That's one of the, again, the neat things that the kidneys do. They'll bring something in to get rid of it later. So you're almost artificially creating a gradient. Again, in the loop of the nephron, whether it's the long loops or the short loops, descending limb, permeable to water, not solute, ascending limb, water, impermeable, but solutes are able to move that thick this thick segment, okay? The thin segment, water and even sodium can move. The thick segment, you have symporters and antiporters moving things in and out. By definition, those are active transport, and energy is expended. The distal convoluted tubule, even though the vast majority of what it does is secretion, again, the vast majority system-wide of reabsorption and secretion is proximal. The distal convoluted tubule is sort of, if I would say it, finalizing it. There is some reabsorption. That's where the antidiuretic hormone, again, collecting ducts will insert those aquaporins, water reabsorption. The aldosterone will target the collecting ducts in the distal convoluted tubule. It'll promote these apical sodium and potassium channels that are there. And again, what will happen because of those things that are entered in there, sodium will be reabsorbed, water will follow it. And so without aldosterone, we would lose sodium to the tune of 2%. So if for some reason someone had a fault in their adrenal cortex, we'd have to find some way to have something to retain that or compensate for it. And so what is it doing? You're retaining fluid, you're increasing water, and you're decreasing, because inevitably as sodium comes in, potassium kicks out. Again, that's part of the big problem with diuretics. For years, we had things that brought in sodium and water, but we didn't spare the potassium, and potassium got too low. And if you go back and listen to the cardiac unit, that creates arrhythmias, instability. So it's a big thing. We use a lot of those agents to take care of people with heart problems. And the problem was now you're trying to manage different medications back then with diuresis, lowering potassium levels. So you're trying to achieve a delicate balance. That's why they kind of did away with diuretics. Not entirely. We use them more judiciously in a hospital setting. So again, we talked about this is the opposite, the so-called anti-aldosterone. Stretching the atria releases this particular peptide, atrionatriuretic peptide. Atrial cells, if there's too much pressure, parathyroid hormone, we know it acts in that area to increase calcium. This is a nice little chart to show you what goes on without me going over it. And so that pretty much, and you can look through all of these little things. Again, in the interest, tubular secretion, reabsorption and reverse. Again, it's mostly in the proximal convoluted tubule. So we secrete those two substances. We want to get rid of potassium, acidity, hydrogen ions, ammonium, creatinine, different things. Okay. Bicarbonate actually goes there to neutralize some of the protons that are being, and you can see what's happening. And so disposing of substances, drugs are metabolites bound to plasma proteins, undesirable substances that were previously passively reabsorbed, urea and uric acid. We have a limited tolerance for both of those nitrogenous wastes. Potassium, aldosterone, if it's excessive, and controlling the pH by altering the amounts of hydrogen ions and bicarbonate in the urine. So all of that's there. This is just a neat little summary. And that basically concludes. This is where we're starting. This is the countercurrent mechanism. We'll start with that. I mean, if I'm not too hoarse after this hour and 20 minutes marathon. Thank you. You're done. See ya. Have fun storming the castle.